Did you know that 1 in 2 IMGs fail SCA? And do you want to know what's the reason that IMGs struggle so much with the SCA, whereas the UK graduates tend to do well for the exam? The truth is that UK graduates have a home advantage. They've been speaking English all their life. They understand the NHS. In medical school, they've received training on communication skills. If you're an IMG, chances are English is not your first language. You may not have received enough communication training in your med school days. If you drop a UK graduate in India and maybe they don't speak Hindi and they don't know the system, they are going to struggle in that system. You might not like it, but this is the reality. So if you move to the UK and want to become a GP here, you have to catch up on the work that you may not have been doing in your undergrad, and it will take you more time and effort to put in that work to level up. Let me be clear, as an IMG, it doesn't mean that you can't pass your exam first attempt with high score. Let me give you an example of Dr. Randika, who passed his exam with a score of 99 on his first attempt.
I needed to put extra effort in, being new to the system, obviously not having communication skills training. So I started looking at the SCA somewhere around, say, July last year, so around July, August. And I started preparing, started going through cases with friends, and I went through the RCGP, the videos, as well as the statement, and sort of tried to understand what was going on. I think you have to start from somewhere, and obviously starting from the RCGP statements is a very good place. And then I think started practicing. I did weekly practice with my friends, and it wasn't just with the same study group as well. I tried to practice with as many people as I could, try to get different viewpoints. And I tried to practice with as many resources I could as well. And that obviously compounded over time. And there was a point where I was thinking, I can't progress further because I wasn't sure what I needed to do. There is a point where obviously, your colleagues will critique you, but then again, there is a point where, there's fine tuning needed to be done. And I think that's when I got in touch with you. And obviously we started our one-on-one sessions, so that was very, very helpful as well. And I think if I were to give advice about preparation, I would say start early, practice as much as you can, not just with one group, with different people, and get professional help if you feel like you need it as well. And I think you did help me. And there was a period of time where I wasn't seeing patients in between, obviously, when I was in limbo, like I mentioned earlier. And I think that practice, or the practice I did with you, was very, very helpful. I think I managed to not break my momentum, if you know what I mean.
So one of the things that I've noticed is that some people who have problems with stammers, it has an issue on their confidence. Tell us, how did you overcome this problem?
So I think I stammer, so you can perhaps see. I mean, it's not exactly like a particularly fixed stammer, but sometimes when my thought process lags a little bit behind my voice. So I think when I'm not confident, that tends to happen a lot more. Um, with time, I managed to get more confident in what I was saying, managed to become more concise, and I think that went a long way towards reducing that. In the exam, I didn't experience it at all. It wasn't there. It
Great.
wasn't there at all.
So you had a really good training where you were trained to a very high standard, and then when you went in the exam, you didn't have that issue. So tell us about one of the problems people have is with breaking bad news and discussion of results. Did you have any specific structure when you approached that?
So I think when it came to breaking bad news, especially with breaking bad news, the important thing is to just get a quick overview. For me, it was to get a quick overview of what the context was, going through the results, and obviously what the patient was sort of expecting. Was that trying to get the ice very early on was the main key, and then it was breaking the bad news as early as I could after getting that context without sort of delaying it. Same goes for the results, trying to build up a picture of why the results were done, what the patient is expecting, what the results are. I think I did try and sort of give the results out, say around the 3 to 4 minute mark after I got those ideas, and then it would be a discussion about what the results meant, what we can do moving forwards. And I think that structure helped me well. So it was context, ice, results, then the fine tuning of the history taking, and then of the data gathering, and then the management after 6 minutes.
Let's talk about ice specifically. So some people, they elicit ice in a way that's sounding a bit like formulaic. What were you doing when you elicited ice?
So I think the important thing with ice is that the best way to get ice is for it to come out organically. You know what I mean? If the patient sort of says, starts the consultation saying, I'm worried about something, then that's the time to explore that. Don't sort of leave that for it. Oh, are you worried about something? Just don't leave that cue. Um, and I think for me it was easy when I sort of explored it organically. So when I explored the worries, then the ideas came out, and then when the ideas came out, you could then go on to the expectations, and it didn't feel like it was a script. So before, obviously, I would say, oh, what do you think is going on, and then what are your concerns, and then what do you want to happen? I mean, that felt like I was just ticking a box. But then for it to feel like a conversation, it has to come out organically. And I think patients, it will come out organically. In the exam, there were a lot of agendas, and I think because I followed the pattern of getting it out organically, the role players felt like they had to give me their eyes, because it came out organically. And I think it really helped. It really helped.
When you build rapport with the patient and have that conversation, it's a two-way street. It's not just interrogation. Then the patient is more open to tell you. So share with us about the management. What were the things that you did in the management?
With regards to the management, I had a structure for the management. So the structure in broad strokes was obviously a conversation with the patient saying, look, this is what you've got. So it was verbalizing the diagnosis and explaining the diagnosis that I managed to do for all of the cases. You have to do that because you have to have something to, base what you're going to do moving forwards. The next thing that I managed to do was try to sort of lay out in broad strokes. So this is what you can do, this is what I can do, and this is what we can do together. And things that you can do was obviously the lifestyle changes, things that they could do themselves. Things that I could do, maybe arrange for medications, maybe arrange for tests, maybe arrange for referrals. Those are the three things I thought I could do. Things we could do together was basically things like following up, planning forward, sort of, troubleshooting. Those were the things that I sort of set out. And I think that structure helped me really well because I always had that in mind. And I always, when I saw the case, I just jotted down on the whiteboard that this is what I think is going on. This is what I want to happen. And I was always able to refer back to it and discuss that with the patient.
So it was clear in your mind, you were
Yes,
organized, and that's where when you actually implemented it, it was quite straightforward. Tell us,
exactly.
on the day of the exam, like what was the hardest things that you found on the day of the exam? Was it some people they find it's really long day, they're tired? What was your experience?
My experience, I have to agree with that. My experience was the stamina. I mean, to be honest, it's a very tiring exam. You do get a lot of brain fatigue towards the end. So the exam is broken up into 6 cases each, and there's a 10-minute break in between. But by the sixth case, your brain is frazzled. I think your structure starts going out the window, and then it's difficult to stick to things. I think it's why you have to try and practice as much as you can. I think try and practice in longer blocks. Try not to just practice one case and then sort of go on to analyze that. Just practice maybe 3 cases in a row and build up that stamina. That is what I was going to say, because yeah, that was very, very difficult. Sometimes I start forgetting what I'm going to ask next. I sometimes had the issue of mixing up what happened before. Thankfully I managed to sort of not let that affect me. But yeah, there were times that I was mixing up patient details and things. And yeah, no, you have to make sure that you are in the moment and you've forgotten the previous case. That was the most difficult thing for me, I think.
When it comes to managing uncertainty, what were the things that you would say were good that you managed to do to manage uncertainty well? If you found this video useful, you might want to watch the whole interview here. Click here to watch it. Take care, everybody. Bye bye.